Good afternoon and welcome to your monthly Citizen CPR Foundation Champions webinar. I'm your host, David Hiltz, and we have a great deal to share with you today. I'm pleased that you are joining us and taking a deeper dive into the respective subjects of drowning prevention and treatment. We are absolutely delighted to have some fantastic guests joining us for this important and timely discussion in just a few minutes. As we get underway, please mute your microphones and use the chat function to capture your questions during this webcast. These webinars are for you and your communities, and as such, please provide us with your feedback. We ask that participants be respectful at all times and refrain from sharing negative or degrading comments, as well as specific product and service promotions. Any images of products appearing in these webinars are for discussion purposes only and do not represent endorsement by the Citizen CPR Foundation. As your host and on behalf of the Citizen CPR Foundation, we are proud to recognize and thank our partner council members for their generous support. Without this support, programs such as this webcast would not be possible. The mission of the Citizen CPR Foundation is to save lives from sudden cardiac arrest by stimulating effective community, professional, and citizen action. Through our Heart Safe initiative, the foundation intends to guide, empower, and enable communities to strengthen local stakeholder collaboration, encourage data collection, analysis, and dissemination, the facilitation and implementation of life-saving strategies, the promotion of public education and training, the improvement in delivery of high-quality resuscitation and post-arrest care, and enhancing the impact of cardiac arrest therapies. This webinar is part of this larger, important effort. I have a few reminders for you today. We'll get through those rather quickly. Please look for important information in your post-webinar email regarding an academic research study regarding cardiac emergency preparedness in youth athletics. The study objective is to evaluate the level of preparation, training of personnel, and availability of AEDs for responding to emergencies in the setting of youth athletics. And the survey is directed at parents, coaches, administrators, and athletic trainers. This is a clear action request. Your participation and assistance in the distribution of this survey is greatly appreciated. We also are delighted to let you know that we have a pair of assets, including a report card of sorts and a tracking tool, along with an implementation and resource guide that should help you with the implementation of life-saving strategies within your own communities and systems of care. As a segue to the topic of drowning, I have a video to share with you. And if the gods of technology will bless us, it will play for you now. So that was certainly a high impact video underscoring the value of learning CPR. However, as we will discover, there is a great more in solving the issues associated with preventable death and disability from drowning than simply training in CPR. Drowning is a complex problem. Like sudden cardiac arrest, the process can be interrupted and tragic deaths can be avoided. To be effective, organizations, that would be you, me, and us, need to leverage our collective strengths and work together in order to have the greatest impact. Now, a couple of quick facts for you all. There are 10 fatal drownings each day in the United States alone. And by the way, outside of the United States, it is potentially an even larger issue. Drowning is the leading cause of unintentional injury related death for children ages 1 to 4 and remains in the top 5 causes of unintentional injury related death from birth to 54 years of age. Based on 2016 data, there were approximately 10,000 emergency department visits for non-fatal submersion injuries. 1 in 4 pediatric drownings occur at a family gathering where a pool is also present. Of note, boats, drugs, and alcohol are large contributors and exponentially more lethal when combined. Layers of protection and swimming competency appear to offer the greatest promise in saving lives. Now, we are joined today by our guest co-host, Dr. Justin Sempsrott. When it comes to the subject of drowning and his extensive involvement in the treatment and prevention of drowning, Justin has significant perspective to share. Joining Justin and I is Laura Metra of the National Drowning Prevention Alliance, who will share a very personal story and an expanded discussion regarding prevention strategies and tactics. Welcome, Justin and Laura. Now, we're going to drop the visuals so we can see our esteemed guests. And there we go. So I'd like to call on Justin first. And I'm going to ask Justin to please say a few words about himself, introducing himself to our group. And then we're going to have a question and answer conversation together. So Justin, would you tell us a little bit about yourself, sir?
Hi, thank you so much, David, for inviting me on. And thank you to all the participants for carving time out of all of your busy days. So I am an ER doctor by day, and I started out as a beach lifeguard in Northeast Florida in 1996, and that's when I just absolutely fell in love with the ocean. And believe it or not, I never wanted to go to medical school. I just wanted to be a lifeguard forever. And so even after finishing undergrad and pre-med, I decided that I wanted to be a lifeguard. And in the path to becoming a potentially full-time career lifeguard, got my EMT firefighter and was in paramedic school. And it was while we were in paramedic school, some other of the lifeguard supervisors and I, that we got to the drowning chapter, and it was about a paragraph long. And the three of us raised...
Just yes, Adam Ketchmarchi, the executive director of the National Drowning Prevention Alliance, wanted to say hello to Justin.
Hi, Justin.
He is our executive director. So
wow, what a great surprise. Thank you, Laura.
There you go. My pleasure. We're at our conference, but I'll talk about that at my turn. I had to do that quick interruption.
Yeah, no problem at all. Good to see you, Laura and Adam. So when presented with that, the three of us raised our hands and said, hey, just so you know, that's not what our practical experience is. And we were told, well, that's what's in the textbook, so that's what it is. And that was kind of my big push to go to medical school to better understand drowning and to join the small fraternity at the time of lifeguards turned physicians that were dedicated to studying and understanding drowning. And I keep those early experiences very close and spend a lot of my time training lifeguards and pre-hospital personnel, as well as lay responders, because there's more that those populations can do for the prevention of drowning, obviously, but even for the rescue and treatment of drowning, they can often do more than what we can do in the hospital. And so I've really dedicated to try and bring that message home. And then the other side of that coin is, as you alluded to, more than 90% of the world's drowning deaths are in low and middle income countries. And so I co-founded and serve as the executive director for Lifeguards Without Borders. And then to help promote the research side of things, I'm a co-founder of the International Drowning Researchers Alliance. And so we work together to share information in a non-competitive, collegial and collective way to improve the transition from lab to life-saving for drowning prevention, rescue, and treatment science.
Wow, Justin, that was excellent. You knocked off a couple of the questions that I had. Like, so tell us about yourself, and then how did you kind of land where you are? So you did an exceptional job there, and that frees up time to talk about some more important kind of things that are related to our discussion today. So, like, I know that you are involved with the ILCOR group around kind of evaluating current evidence, science, and treatment recommendations related to drowning. I think there may be 7 questions that you and your team are looking at, and we probably couldn't do all 7 good service today, given the time, but I'm going to ask for you to kind of cherry pick a couple from there based on your wisdom as a subject matter expert here. And like, what are kind of, if you're looking into your crystal ball and from those 7 things, where would you start? What's the number 1 question that your group is looking at? Please share. We have open ears and we're all listening intently.
Yeah, absolutely. And the brief elevator pitch segue into that is how is drowning resuscitation different from kind of the standard cardiac resuscitation? And for all of the out-of-hospital cardiac arrests that occur in the U.S. every year, about 20 to 25% of those are VFib or VTAC arrests, which is where we know that through use of an AED, the public has the chance to have the most impact. The deaths due to trauma, liver failure, kidney failure, sepsis, those get a little bit more complex, and there's not as easy of a solution as having an AED that's readily available. And so that's really the focus of a lot of community CPR programs. And when that person has a sudden cardiac arrest, there's often still oxygen dissolved in the blood. And so we do compression-only CPR to circulate the oxygen that's already there until an AED can be applied. And so it really is a setup for success for public intervention. For drowning, the drowning person that's trapped underwater, their oxygen levels start to drop. And you can imagine their pulse ox would be 100%, 70%, 20%, 0. At some point, they run out of enough oxygen for the heart to continue beating and go into usually a pulseless electrical activity or PEA arrest, and then on to asystole. So as they're pulled out of the water, they've depleted all of their oxygen. So doing compression-only CPR is really just circulating that deoxygenated blood, and less than 10% of your drowning patients are in a shockable rhythm. So rapid application of an AED may not be the most effective intervention. So it's really about getting those breaths to the person in addition to doing high quality chest compressions. So for those of us that have been doing this for a while, you'll remember that our CPR training used to always be to do breaths and compressions, but especially to the average soccer mom or soccer dad who is outside of the medical field that is not doing this every day, then those breaths are difficult to deliver, especially when it's your own child, your own parent that you're performing them on. And we found that simplifying to compression only and the AED saved more lives. So as we've kind of come full circle with that, is the public has received excellent training, and there are numerous agencies and even the kiosks at the airport and such where we've really simplified addressing those sudden cardiac arrests and that training. And so now how do we add back in some of those rescue breaths for cardiac arrest caused by drowning? And how do we increase the public awareness of that without it being at the expense of increasing confusion for the treatment of sudden cardiac arrest from cardiac causes? So as we move into now the PICO questions, the population intervention comparator and outcome questions at ILCOR, which is the International Liaison Committee on Resuscitation, of which they put together the science and treatment recommendations that then the American Heart Association, European Resuscitation Council, Australia, New Zealand Council, et cetera, around the world build their guidelines from. And so we're looking now for laypersons or the rescuers taking CPR classes. Should they be doing ABC, airway, breathing, then compressions? Should they be starting with compressions and then doing airway and breathing? Is there going to be a difference in survival? Is there going to be a difference in survival with a favorable neurologic outcome? Should we be teaching that 15 to 20 second delay of doing compressions for a cycle of compressions first versus breaths first? Does it matter? Or is the reality that, you know what, EMS with advanced equipment is going to be 8+ minutes away? It doesn't really matter once you're 6-7 minutes into this, as long as you're doing both. And so we can simplify the teaching and say that perfect is the enemy, or good is the enemy of better, right? That we can just let's keep it simple and not have too many different treatment paradigms. And so that is one of the more urgent ones, and that was the first one that we put forward that has already gone through the public comment period and is back to ILCOR. And so then the next step in that progression is there even a difference between in outcomes from compression only versus the conventional, whether it be ABC or CAB? And can we simplify this even further, or can we validate our current practice and say that, yes, we understand the physiology, yes, we understand that the person needs breaths, but maybe compression only really is good enough, and that we don't need to be focusing as much on the breaths. Frequently, a question that I get around that is the classic teaching of, well, as we're doing chest compressions, you're getting movement of the chest and you're generating negative pressure, and aren't they getting adequate breaths that way? And that works often on mannequins and in theory, but the reality is without an open airway, that can be very difficult to achieve. And so that's something that kind of comes into the consideration for that. And I can tell you that the data is limited. And for most of these questions, it's going to be 1 or 2 studies that fit into that systematic review framework. And the remainder is going to be on expert opinion. So I think what is going to be the next kind of big question that we're looking at is, do we put the AED on somebody first after they've been rescued from drowning, as opposed to maybe doing a few minutes of compressions and ventilations, and then incorporating the AED. Whereas I like to joke, in the sudden cardiac arrest, you should use the AED to knock everybody out of the way except the one person doing chest compressions to get it on them as quickly as possible. That may not be as appropriate in drowning, and so we're looking to look at that through systematic review to see where can we deviate from those standard guidelines with good data behind us, again, without making it too confusing or creating a whole separate pathway.
Interesting. You know, it all seems so simple, pardon the pun, on the surface level, right? Lifeguards, whistles, sunblock, polarized sunglasses, but you know, and a CPR card and surf rescue testing. But good Lord, there's a great deal more to this. You know, we're looking at, do we consider drowning to be a special circumstance for the healthcare provider community? You know, we need to take into consideration primary VF that occurs in the water, much like primary VF occurs behind the wheel of a car, and sometimes interpreted as a traumatic primary incidents when it's not the case. You know, does asphyxial arrest demand, you know, an alteration in our approach with, you know, an increased value on airway support and ventilations? So there's a lot of, you know, great questions here. Tell us a little bit more, Justin, about the evolution of science and treatment recommendations at this point.
Yeah, absolutely. And you mentioned the role of the surf lifeguard, and even your video in the beginning from the Sea Scouts in South Africa. I actually reached out to them yesterday, not knowing that you had that video in there, and so we may have some folks from the South Africa Sea Scouts on this presentation as well. They do tremendous work, but it's also thinking about the lay responder as well, and thinking about the parents that are taking CPR because they have a pool, because they have kids, because they want to be prepared for that, and how that may be different. Those guidelines may be different than somebody that's taking CPR because they're caring for their elderly parents, or because they are working at a senior center or community center and such. And so we want to make sure that those things that go through the scientific process aren't just for the professional lifesavers or the professional EMS, but also applicable to the lay person as well. And particularly around the world where you may not have access to bag valve masks or supplemental oxygen, it can be hard to make a recommendation that the standard of care is to use a BVM and oxygen, when perhaps the outcomes might be the same, just with mouth to mouth with a simple barrier device. And so those are actually two of the questions that we're looking at as well. Is, does pre-hospital oxygen impact the outcome? And does the use of an advanced airway device, such as a bag valve mask, a supraglottic airway, or endotracheal intubation, improve the outcomes over perhaps, you know, somebody in sub-Saharan Africa or Southeast Asia, where EMS may be several hours away? Can they start that resuscitation with just mouth to mouth?
Yeah. You know, again, it's like, I'm looking at the landscape. I live, you know, in a shoreline community. Outside of myself, my entire family, my wife and 3 boys are all come from lifeguarding. They maintain that status. And, you know, there's an issue of accessibility at this point in time. So like, and I remember when my boys would be placed in a lifeguard chair as a single guard, right? With a radio that was probably not as dependable as one might like. And, we've got all this stuff, and it's like, just put seats in those chairs has got to be the reality for many communities, whether it's a pool chair or a beach chair. Get a butt in there. Let's make sure they've got their old credential, whatever, certifying body that might be, and we're off to the races. Good Lord, talk about a high risk set of circumstances, knowing that even the most qualified lifeguards may not be the answer to the problem here. Unnecessary and preventable deaths. This is a process that we can prevent, and we're going to get to Laura on that, but we can also interrupt the process in a variety of different ways. How many organizations are understanding the value of in situ exercises and real life competitions? Rather than, hey, show me your CPR card, show me your surf test card. Okay, you're good to go. Click, click on the radio. So we've got another 2 minutes. I want to indulge Justin here, right? Because there's a lot here, right? 1 hour of discussion does not do this subject service, but and we're going to come back. I see some great questions already posed. We're going to defer those till the end. But Justin, if I'm a manager of a lifeguard service, like I'm a YMCA aquatics director, or I manage a group of surf rescue guys and gals, what would be your top 3 recommendations? Don't dismiss me to that particular audience before we transition to Laura.
Yeah, great question, and I love it because my answer is completely off the cuff, since this was an unprepared. But my first would be that you absolutely have to train the way you fight, and that is, if you are used to seeing a drowning person as screaming and waving for help in the movies, then that's what you're going to look for, and you're going to miss the person that silently sinks under the water. If you're training only on those little plastic half Adonis body mannequins, then the first time that you see an actual drowning patient vomit or have foam or even be cyanotic, then you're going to freeze and not know what to do. And that's not a judgment on the lifeguard, because nobody rises to the occasion. Everybody falls back to their level of training. And so it has to absolutely be to train the way you fight. The second would be to really emphasize to lifeguards that what they do matters. And it is so difficult to train somebody to do something to an expert level that you hope they never ever have to do. And it's these high acuity, low occurrence events that you have to train to, and it has to become muscle memory and hope that you never have to use it. But when it happens, then that expectation is that you're going to perform at that professional rescuer level. And what happens, obviously on the prevention side being the most important, but even just talking about treatment, that the treatment started at the pool side or at the beach side is more important than what we can do in the hospital. And
that's good, that's good. That's good, right? And I think where you're going with the third thing is let's get innovative, right? So I'll pick on our friends down in the land of Oz, right? Oh, well, let's train surfers, right? To be capable and willing to rescue, right? Because they're in a position to do that. And early care, makes a difference. So, train like you fight. Consider the context of how you do that training, right? And then, HALO, high acuity, low occurrence, is a reality. And so to put a high schooler who's a great swimmer, who goes through a BLS course and lifeguard training and surf rescue certification, beginner's permit, right? not okay, we're all set. So that was phenomenal. Justin, thank you. And so now I'm going to turn over. So Justin has this other label of co-host, and he and Laura happen to know one another. So I am passing the proverbial microphone to Justin to have a conversation with Laura about, prevention is key. So it's over to the two of you. Justin, have at it.
Thank you so much, David. Laura, welcome. Glad you're able to step away from where you're actually hosting a conference of the National Drowning Prevention Alliance. So it's getting very meta with the webinar inside of the conference. So thank you so much for taking the time to join us. I was trying to think as you were joining that I think we first met 6 or 7 years ago, something along those lines.
8
years ago at a conference, and it was a wonderful reality check for me because sometimes I get caught up in the doctoring and the instructing side of things that I forget how that science has to translate down to the average person on the street in that exact moment. And I think that's what struck me so much about your story. And so I will turn it over to you now to introduce yourself as well as tell your story about how you wound up kind of on the conference circuit with us.
Absolutely. And, before I tell my story, I just want to say I love that conversation that you're talking about just now. I think there is sort of a step process of the levels of understanding, and sort of where do you introduce somebody to this concept versus where they may go with that concept later in terms of their skill level, because really the introduction, to the layman, I think if, simulating vomit and or foam out of someone's mouth was the introduction to the layman, I'm not sure we would ever train anyone in CPR. Let's just be clear to ourselves right now. This would be a PR nightmare. Okay. So I would not suggest that at the intro level, perhaps, but it's true, but I will back up and just tell you again, my name is Laura Metro and I'm from the Washington, D.C. area. And I currently am the Director of Marketing and Communications for the National Drowning Prevention Alliance. I was a board member for a long time and did a lot of that work for them. And then recently actually moved over to staff. In addition to that, I have a foundation that I run called CPR Party. And what this was something like, if you think of the in-home shopping party format. So if you think of, Tupperware, you think of, makeup, the in-home shopping party, take the shopping out, put CPR in, non-certification, quick and dirty, learn what you need to learn kind of thing. It was really what we did. We had a tremendous amount of success in doing that and a lot of notoriety. But it was really difficult to scale this program, which was really interesting. And then COVID hit, which was really great because it gave me an opportunity to sort of slow down and determine kind of where I wanted this to go from there. So that's sort of, where the foundation is. But backing up, there was a cause for this foundation to be created, which was my husband, my family and I and some other family were at the beach on the Delaware shore. We were actually our kids were all gonna go swimming in the community pool. And my husband and I were going to take, we were dog sitting and house sitting at my dad's house. And we're going to go on a run. And my friend said, both of you just go on the run. We'll watch the kids by the pool. So they had 2 kids and we had 2 kids. And my son was 3.5 at the time. He did, I'm going to tell you now, make a full recovery so you guys can breathe when you go through this. But he was 3.5 at the time. And my daughter was 6.5. And my husband and I came into the development and my daughter came running out of the pool and she was screaming, I think Clay died. I think Clay died. And I did not hear that, what she said. I just sort of noticed a lot of commotion. And then our friend came out and, you can tell a shriek of horror when you hear one. So we started running into the pool area where my son was, gray and lifeless on the pool deck. And our friend who didn't really know CPR, he just had sort of seen it on TV, maybe had done like you guys were talking about, like some compressions here or there, maybe in high school, was trying to administer CPR. At that point, chaos sort of ensued, and I did apparently go in to try to do compressions, and there was a gentleman there that was sort of took on his role of coach to our friend, and I guess he felt that I was doing things too hard or something. He did not think that I was the right person to be doing that at the time, so he actually had said, I think you should go over here. So to make a very long story short, the paramedics arrived. They did use an AED. They did, they did get a faint heartbeat back. They did start CPR. They did actually hypothermia treatment as well. We were medevaced about 2 hours, 2 hours by car, about a half an hour away to Morris DuPont Children's Hospital, Wilmington, Delaware, where he was in a coma for 2 days. And then he woke to make nothing short of a miraculous and total recovery. So for those who are in this space, they know this is really absolutely not the normal story. The doctors at the end of the day said the only thing that we can attribute to this was the bystander CPR, because when it comes down to it, we did not see the inside of an ER for an hour and a half. So, and they were losing him in the helicopter, going back and forth. So for me, when the dust settled and we finally went home, I became obsessed with why I didn't know CPR, and B, my son had been in 2 semesters of swim lessons, but it looks like he had fallen in and sank. So from what we understand happened, he was walking from one friend to the next. None of the kids were in the pool. They were having a snack, and he was going over to get a snack, and there was a blind spot. So, wife thinks that Clay's heading that direction. Husband doesn't know he's responsible for Clay yet because he hasn't arrived. We believe he tripped on his towel and fell in the deep end because he was found on the bottom with the towel. So we'll never really know, but basically one of the other children saw him at the bottom and alerted them. So for me, when I look at, I started to look into things, and the big question was why I didn't know CPR. Why did I not know this? Why was I not proficient in this? Then I started to get, on the surface level, I laugh because of how deeply involved in this space I am now, but on the surface level, and started to see these stats on drowning. And again, why didn't I know this? What is happening here? And when I looked at the stats and I looked at what it was, here I was a Caucasian, college educated woman who lives 3 miles outside of Washington, D.C., and I didn't know this. So how many other people in this country do not know this? And it became a rabbit hole that I'm still in a decade later. So this is the biggest rabbit hole known to man. So I got involved in that and said, I need to do something. And my background is in PR and marketing. So I thought to myself, I need to find an easy format, something, anything, because it really came to me that knowing something was better than knowing nothing at all. Because if you don't act, they're going to die. That's it. There is no, 85% of the people die on the way to the hospital with cardiac arrest. They're going to die, or they'll live. And this is a big piece to this too. Living is a very big spectrum. So what I would like to see is people thriving, walking out of a hospital, okay, alive and thriving with full cognitive ability. I don't necessarily know if living and having very low ability and needing lifelong care is living. So, we have a big spectrum here of whether someone is going to be alive or whether someone's going to be thriving in life. And so that's really what was driving me, in addition to not wanting any, of course, family to ever experience what I experienced and going through this. And so that is when I became involved in the National Drowning Prevention Alliance, just as a person that was attending, with this foundation, and got heavily involved. And like I said, right now we are having our virtual and in-person conference in Fort Worth for the National Drowning Prevention Alliance. And I'm upset because you guys would love the general session that's going to come starting at 3:45 here Central Time, which is Dr. Ben Hoffman. So I'm not sure if you know Justin, Ben Hoffman. I mentioned you to him. He said he did know you, but Ben Hoffman is the chief of the Council of Injury, Violence, and Poison Prevention for the American Academy of Pediatrics. And so he is also the new chief medical officer for National Drowning Prevention Alliance. So he's going to be speaking. I'm like trying to figure out how I'm going to get you in there, Justin, so you can watch this, but I'm sure it'll be a video, and I'll try to see if I can make it available to everyone on this webinar. I actually texted the group to think maybe I could get a link or a code, because it sounds like people might be interested in even seeing the next virtual 2 days of the conference or something too. So I'm going to work with you guys on that later. But I think for me, what I would just say when you were rattling, doing your stats, I think the most important stat, at least for me, that I'd like to mention here to people is that 70% of drownings happen at non-swim times. Okay, so I'm going to say that again. 70% of drowning happens at non-swim times. So how many people do you think dismiss the drowning message and say, oh, well, I watch my kids. I'm fine. I watch my kids by the pool. I watch my kids by the ocean. We're great. Well, most of the time, what we're dealing with, and you mentioned family gatherings. We have a phrase in the space where we say where everybody's watching and nobody's watching. And it does happen a lot in that instance. And, what I like to give is a scenario, the typical scenario we may hear is mom has 3 kids. Mom goes upstairs. The infant was napping. Toddler is downstairs in the playroom. Mom is exhausted. She hasn't slept in 3 months. She comes down. She's cooking dinner. She's doing this. She's not watching her child. Her toddler is sitting in the playroom. He's never gotten out of the door before. Unfortunately, the day before, her husband or a landscaper propped open the gate to the pool because they were edging around it and they left it open. So we have things that we talk about in this space called layers of protection. All right. We're talking about barriers, door alarms. We're talking about, of course, supervision. We're talking about swim lessons. But I'd like to also throw out there one more thing is there is a difference between swim lessons or swim competency. So I did not know truly what my son's competency was in the water. I thought as a mom, he was in swim lessons. I thought that, I was checking this box. And in my mind, I thought for some reason he might be able to doggy paddle to the side or something. I did not know. And I'd say that, to end what I'm saying right now, the number one phrase that we would like to eliminate is the phrase, I didn't know, because it's what we hear every single day. They didn't know. And on top of it, usually they're powerless and don't have these CPR skills, don't even have any skills whatsoever to help in this situation. So I serve on the National Water Safety Committee, as Justin does half my homework for me because this is not my language and I don't understand the research process, as we're being clear here. And I'm calling myself out publicly to Justin and thanking him. But as we serve on that, asking these questions about, well, how is this message, how is this information received by the layman, by normal people? And I can tell you right now, that video that you guys showed would not go over well in the United States, because people would consider it a trigger warning. The US is very sensitive. I'm not sure you've noticed that, but people are very, and I say that because it is very, very difficult to communicate this message. It's very difficult to communicate a message about dying, death, let alone children's death. Yeah. So this is something people don't want to talk about. They don't even want to think about it. So it's really hard at times to really get that nuance to say, well, let me just feed it to you in small doses, okay? So we can give this in a way that you can hear it and understand it. And that's where I feel like I used to joke around that our CPR parties were a total bait and switch. Because one, most of them would think they were coming for hands only, and we would always recommend rescue breaths. We would not force it, but we would say, if you would like to learn rescue breaths, we will teach you. And we would tell them that in the event of a drowning or submersion event, you would need to do rescue breaths. That's what we would say. We also would hopefully people would get the bug and then they would go get certified. But when I did my research, I found that the reason why people weren't getting certified was because they didn't have the money or the time. Unless they were forced to for work or something else, they just weren't going. So there had to be, to me, some type of first step, some type of, and again, if they got something, it was still better than them just standing there not knowing anything at all. And so, it's your turn. I want, Dave, for you to please guide me and guide us in this further discussion. But I hope I, provided some context for my being here.
Yeah, so Laura, thank you for sharing your insight and your personal story. Regretfully, and I'll speak on behalf, probably out of turn for the participants on today's webcast, in that it sounds strikingly familiar to what we are facing in regards to sudden cardiac arrest, right? So we're going to have a little call to action towards the end here. I'm going to do some summaries, but real quick, give us your 1, 2, 3, like, here are the things you can't forget. Give it to us straight up, and let's see if we can't make a difference. Go.
So if Justin is going on sort of the more medical side, I will go on.
Yes.
I think for the layman, I'm going to go on the sort of maybe these tips, a few tips and tricks that like aren't your standard tips and tricks here. Okay. Aren't your standard things that people can read about everywhere. I think what's really important in CPR is understanding, this is my first one, that everyone thinks about CPR and the first thing to think about is either compressions or mouth to mouth. CPR, there are many jobs, I like to say, that are involved in CPR or learning CPR. You could never touch the body of the person that is involved there. You might be the person that is tasked with calming the parents down. You might be the person, because you're on the 95th floor of a high rise in New York City, that's going to go downstairs to the lobby to show the paramedics where to go. You might be the person that's going to find the AED. Or if you maybe have had some training, maybe you don't act first, but maybe you're the second person to take over because the first person's tired. Recognizing and showing people learning CPR does not mean at that very moment that you're going to be the one doing compressions or you're going to be the one. It's also about what is happening around you in this event and making sure that we set up the environment to work well and we make it so our paramedics can get there, so everyone can be in the right place. So someone grabs the AED. I would say in the event of, I will go to my point 2. Okay, so that was the first one, really educating people that I think people feel like if they know CPR, they're going to be kind of on the hook. And I hate to say that, but I think it's reality of the way some people think. Some people don't want to act in this situation. It's almost as though they don't want to know it. They're too afraid, or they don't think they can participate.
Mm-hmm.
Yeah, and it's not because they're a bad person. Most likely they're afraid. Mm-hmm. But when we tell them, no, there's so many other things you can be doing at this time, to ushering. I mean, there are people that took my daughter, who was 6.5, away from the scene, finally, to get us, there's a lot of things that happen in these emergencies that can also lead to an issue. So my second point would say, you say my quick 3. I never do anything quickly, by the way, if you figured that out, I'm so sorry. My second would be what was I going to say? Because I was thinking about it and I lost it. You have your hands up. What were you going to say, Justin?
It's okay, Laura. So this is the beginning of a journey, right? And I'm mindful of the time, and we've got some excellent questions. But I think developing a culture of action, this whole notion of 70% occurrence rate during non-swim time, right? It's like, these are significant. And I also believe that there's, some great opportunities for us to collaborate more closely.
Yes, for sure. My problem is there's so much to talk about.
Yeah, me too.
That my brain is full. I would say the second being layers of protection, including first response in that layer of protection. So we talk about supervision, we talk about barriers, we talk about, alarms, we talk about our first response, we talk about swim competency, swim lessons. So looking up the layers of protection is a very important thing. And lastly, this is a very random tip, but one that I think is important, at least it was in the case of Clay's accident. Like we talked about being at, family gatherings and things like this. Another, coming up into the summertime, most people do what in the summer? They vacation. Okay, so We all know that the, major hospital error occurs in transitions, right? Well, what happens when you go to your Airbnb or your VRBO? You have 5 different families in a house, a giant house. You don't know the house. You're all out of routine, and there's a pool that's in the house. One, be aware of what's going on of the house that you're in, but most importantly, know your address. Know where you are.
Yeah.
Okay. The woman that was on the phone at during Clay's accident was someone visiting the beach.
Oh.
I was yelling emergency
We're at the beach
to
now.
some workers across the way. They were the ones who gave the address. So saving seconds, is so important in this moment. Getting, as when they get to you, having them get to you as soon as possible. Knowing where you are in a space is very, very important. And Matt Payne, he's the head of Mesa Fire Department, and he also said, also make sure your house number is always visible. If your house number is on the curb, it's nighttime and trash day, they don't know, they can't see you, they can't find you. Make sure at night, firefighters or paramedics can see your house number, because you don't have time for them to go to the house before or after yours. And when we talk about thriving versus living, it is those seconds. It is that time that is going to make the difference for you in those moments. And so I feel that those things are not as much talked about, but really easy, important things to know.
Yeah, excellent, Laura. So I'm looking at the time, so we're a little bit pinched, but that's okay. I'm looking at some questions. Richard, Mark, and Deb Hennig have made a couple of questions. I think we might need to follow up on 2 of them outside of the webinar, but to Justin and Laura, very quickly, I think Richard has a great question here. If you had to identify 3 misconceptions about drowning, what would they be? And you need to be ultra brief, because I got to tie this all back together in a timely fashion. Go.
Yeah, I would say that drowning just happens, right? It's unavoidable is a myth. Drowning is preventable. The next would be, just for terminology, drowning does not mean death. We all know people who've had a stroke and survived, some with and some without a deficit. You can drown and survive with or without a deficit. And the last would be that I've said that many times already on this webinar, is that what you do as the parent, as the lifeguard, as that bystander matters, and matters more than what the doctors and paramedics can do.
Yeah, perfect. There's a lot
Yes.
more to running into the water with the rescue buoy and grabbing somebody. There's
Only
a
if you're
lot
trained.
of opportunity.
Only if you're trained. Only if you're trained. Throw, don't go. Throw, don't go.
Yeah.
You do not run in the water. Do not go after them. Throw, don't go, man. Okay, number 1. Number 2, I'm going to quote Justin. He did not say my favorite line that I use of his all the time. You do not drown because you can't swim. You drown because you can't breathe.
Correct.
Number 1. Number 2,
Correct.
I would say that drowning is silent. Drowning does not sound like help, help. That doesn't happen at all, actually. Your body takes over. He could give you the medical. You slowly sink silently into the water. It is not like Jaws. Get it out of your head. That is not what happens. And I'm just going to go right back to your point is, do not go in after people. Throw them a flotation device. And we've talked about different ways that they can be: a jug, a ball. There's all kinds of things around you that could be a flotation device. Throw them something. Throw them a line so you don't become the next victim, because it happens way too often.
Uh-huh. That was exceptional advice. Now, Deb asked a question regarding to predominant presenting rhythm, PEA, and there was another question. We're going to have to address those outside of the webinar today, because I want to kind of wrap things up here. So let's see if we can get things to work in our favor here. All right. So Justin and Laura, thank you for sharing your knowledge and experience with us today. It's been a formative discussion. That's just getting started, right? We also want to thank all the advocate champions in our audience for steadfast efforts to implement change in your own systems and communities, right? Drowning is preventable. A combination of strategies and tactics, including water safety planning, improved supervision, barriers, alarms, water competency, widespread emergency training for the public, and high quality resuscitation standards by professionals can make a significant and life-saving difference. You know, there is hope for saving lives and hearts too young to die, and life-saving represents the ultimate form and expression of hope. However, change is up to each and every one of us, okay? Now, next month, and I am going to try to do something different here. You're all going to get the standard post-webinar communication, but I'm going to try to do a second one. But in any event, mark your calendars and please join us next month as we talk about the recently released scientific statement from ILCOR regarding understanding the importance of lay responder experience and out-of-hospital cardiac arrest. We're all Katie Dainty fans. Regretfully, she can't join us, but I'm going to have somebody else join in. And further to that discussion, we will discuss the opportunities associated with National CPR Week, which, as you know, is the first week of June here in the United States. We really appreciate your feedback as we conclude our program this evening. Please let us know what we can do better. We would like to hear of your feedback and ideas. These are for you. They are not to serve the Citizen CPR Foundation, but the resuscitation community. All right. And then, as always, thank you for your time and all that you do each day to improve outcomes. I am David Hiltz, signing off, and good night.